السلام عليكم ورحمة الله وبركاته. نرحب بكم جميعا في يومنا قبل الأخير للإمرجنسي ميديسين سمر كورس، وإن شاء الله نكون قدرنا نفيدكم في الأيام اللي راحت. وزي ما قلنا قبل، هدفنا من الكورسات دي إن نخلي الجميع يستفيد قدر الإمكان. والآن وفي بداية حديثنا وقبل أي شيء نقول اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. موضوعنا اليوم حيكون عن الجاستروانتستينال emergencies، وحيكون مع الدكتور عمار سامي يماني emergency medicine resident at National Guard Hospital. نرحب بك دكتور عمار، ومحاضرة ممتعة لكم جميعا.
السلام عليكم ورحمة الله وبركاته. أحب أشكر الجمعية على الكورس، إن شاء الله نفيدكم اليوم باللي نقدر عليه. طيب، بسم الله الرحمن الرحيم. اللهم لا سهل إلا ما جعلته سهلا، وأنت إذا شئت جعلت الحزن سهلا. طيب، إن شاء الله اليوم حنتكلم على how to approach to patient with abdominal pain. حنتكلم على بعض الجاستروانتستينال emergency، وحنتكلم عن الابروتش لبيشنت who is coming with gastrointestinal bleeding. Usually in emergency medicine, we see patients according to their symptoms. So always you have to master the approach rather than approaching specific disease. It's not important to you to diagnose the patient rather than ruling out the critical diagnosis. Let's talk about the abdominal pain for a little. So most of the patients with abdominal pain, they usually had a normal vital signs, and they have a benign cause. Almost 40 to 50% of these patients, they have no conclusive diagnosis in the ED. That means when you see the patient, you take the history and physical examination, and you do all your labs. At the end, you have no diagnosis, but still, you know that this patient has no critical diagnosis, so you will discharge him with follow-up. About 50%, they will be discharged with a diagnosis called non-specific abdominal pain. Almost always keep your differential diagnosis as broad as possible, because sometimes patients with metabolic disease or toxic ingestion, they can present with abdominal pain as well. As we said that most of the time the abdominal pain is a benign, is usually caused by a benign diseases, but you have to be careful with some sort of population, like an elderly patient. Why? Because elderly patients, they have atypical presentation. Also, immunocompromised patients who are on chemotherapy or on prolonged course of steroid, they usually have atypical presentation. Their physical examination could be unreliable, and their laboratory result could be misleading. So you have to be cautious with them. Those female who are in childbearing age, they have usually broader spectrum of differential diagnosis that is related to their reproductive system and pregnancy. A patient with previous surgery, also because their abdomen is not virgin, so they have a more risk to have complication, and sometimes the adhesion can cause a lot of complication. Patient with previous history of GI disorder like inflammatory bowel disease like the ulcerative colitis and Crohn's disease, they are also at higher risk to have a complication from their disease. Also, sometimes they could present with new acute surgical issue, but you are relying on maybe this patient have this is a flare of his origin or primary disease. And the last thing, those patients who are have a language barrier with you, they cannot express themselves, or those who has cognitive impairments. So this type of population, You have to be careful with them. You have to be more cautious with them. Let's talk about how we usually preserve the abdominal pain. So the first type of abdominal pain is the visceral pain, and this is usually it's caused by irritation of the visceral layer of the peritoneum. So it give you poor localization of the pain, and usually it originates from the embryonic origin. So, for example, like in case of acute appendicitis, because the appendix is one of the midgut structure, the pain usually will start in the periumbilical area. While when the patient or the inflammation when the inflammation extends to the parietal layer of the peritoneum, they will have the somatic pain because of the irritation of the parietal peritoneum. And this will give you localized pain, and this is what will cause the tenderness on the right iliac fossa. We have the third type of pain, which is the refer pain, and it's usually it's a pain that is far from its source. This is important. Why? Because sometimes patients who have inferior MI, they could present with epigastric pain. Patients who have testicular torsion, they could have a lower abdominal pain rather than testicular pain. So keep in mind to have a wide differential diagnosis. Sometimes it could be the abdomen is the source of the abdominal pain, or sometimes it could be anything else rather than the GI symptoms. For example, patient with AAA, it's a vascular disease, but they usually present with abdominal pain. Okay, this is one of the most important slides for me, especially for those medical students who are going to do their OSCE examination, inshallah, next year, or those intern who are interested in emergency medicine. So this table is usually how we approach every patient in the ER. Usually the nurse will come with a page, or it will come with a front sheet that show the patient data, the chief complaint. It will include the vital signs. Sometimes it will come with ECG. It's not only about the abdominal pain. It could be this approach is applicable for all complaints. So, for example, if you see the front sheet and you say that this patient has abdominal pain, and the patient has a low blood, or the patient has low blood pressure, and you see that the patient has the last menstrual period was 8 weeks ago, the first thing will come to you that this patient could have ectopic pregnancy or rupture ectopic pregnancy. Usually, when you have the chief complaint and the vital sign, it could give you a wide differential. So when you see the patient, you will have a better judgment. But this could give you the hint about your differential diagnosis. After that, you will move to the next step, which is how the patient look. It's important to know if the patient is in pain, if the patient look sick or not. And we have the ABC, and here the ABC, it's not only about the airway, also about the appearance of the patient, the pattern of the breathing, and the C for the color of the patient and the level of consciousness. So if the patient is if he is looking sick and he has abnormal vital sign, now you have to think, is this patient is critical or not? This shall I put this patient on monitor bed, or shall I keep him in acute area where the surface will be a little bit delayed, rather than not like the critical care where all the nurses will help you, and everything will be done in a minute. After that, if the patient is critically ill, you will go through the ABCDE, which is the primary survey, like in the trauma. And whenever you have a problem in any one of these alphabet, you have to fix it. So the A stands for the airway. Okay, if the patient came with the abdominal pain and he has a repetitive vomiting with blood, sometimes you are afraid of that the patient could have aspiration pneumonia after the repeated vomiting. So you have to secure his airway. Sometimes the patient, maybe they can become drowsy, so their level of consciousness could be dropped, and they cannot control their airway, so you have to intubate them. The B stand for breathing. Usually they will not be hypoxic, those patient who has abdominal pain, but it could be secondary to a complication. Like in case of pancreatitis, sometimes some patients with severe pancreatitis, they could have a lung pleural effusion, and they have lung issue. So you will decide if this patient need any urgent intervention at that time. Moving to the C, so if the patient is hypotensive, for example, you will start to have 2 IV cannula. You will start IV fluid. If the patient in pain, you will give him analgesia. If you think that the patient has a bleeding, so you will ask from now for blood transfusion. Regarding the D, it's usually about how if the patient is confused, the GCS, and if there is any signs of lateralization. Also, the blood glucose is important. And the exposure, and the last thing, could give you a proper hint about this abdominal pain. Sometimes patients who are immunocompromised, they will become septic, okay? And sometimes they have a severe pain. I think 2 days ago, we have a patient like this, and he has a severe abdominal pain, and when we expose his abdomen, he has shingle. So not all abdominal pain is related to the GI symptoms. It's always important to expose the patient. Sometimes patient with cirrhosis, when you expose their abdomen, you will see the signs of liver cirrhosis. It will give you a hint what is going on. If the patient is critically, as we said, we have to intervene with each step. So we will fix the airway, will fix the breathing, will fix his circulation accordingly until he becomes a stable patient. After that, we can move to history of presenting illness. As we know that all of us know the Socrates and ample history. This is more specific and more focused. You can do this within 5 minutes or less. So if the patient came with abdominal pain, you have to ask about the site, onset, character, radiation, and so on. Ample history is important because you have to know if the patient has an allergy, if the patient has any medication that could cause abdominal pain, if there is any previous medical or surgical history. Regarding the systemic review, usually in the emergency medicine, we will not ask haphazardly. We usually ask specific question that is related to the chief complaint to rule out the other critical diagnosis. So if the patient came with epigastric pain, now when you finish the history of presenting illness regarding the Socrates, after that you will ask the patient if this pain is exertional, because you are thinking about MI, for example. You have to ask the patient if the pain is radiated to the back, or if the patient, when he is lying down, the pain will become worse, and when he sit up, the pain improve. You will think about you want to rule out also pericarditis. You will ask the patient about any previous history of smoking or any previous history of abdominal surgery or aortic surgery, because sometimes you are thinking about AAA. If the patient is a pregnant lady and she has lower abdominal pain, you have to ask about the pregnancy status, because you are thinking about ectopic pregnancy. You will ask about the urinary symptoms. It could be a UTI. So almost always, you have to have a specific question that is related to the chief complaint, not only go through all the systems without know what you are asking about. The physical examination in ER, usually it is a focused examination. So first of all, if the patient came with abdominal pain, my main concern is the abdominal examination. Sometimes I will do the abdominal examination before doing the respiratory examination. Sometimes also we do not do the chest examination if we do not think that there is something related to the complaint. But in the exams, you have to ask about everything. It's also important not to forget to examine the genitalia, especially for this patient who has a lower abdominal pain, because sometimes testicular pain, it will only show a lower abdominal pain, or sometimes the patient will not tell you that I have a testicular pain. He only will tell you that I have a lower abdominal pain. You have to expose the skin. As I said, sometimes maybe all the pain, it could be from a dermatological issue. After that, when you take the history and take the your physical examination, you will order the laboratory investigation that will help you to narrow your differentials and to rule out other diagnoses. Like if the patient has epigastric pain that is related to food associated with repeated vomiting and the pain is radiated to the back, it's important. And the picture, it could be most likely that the patient has pancreatitis. So we'll ask about lipase. You will ask about the CBC, but also it is important if the patient is elderly and has a high risk for cardiac issue to order the cardiac enzyme and troponin in this case. So you almost always will do labs to rule in our provisional diagnosis and to rule out the other critical diagnosis. Regarding the imaging, we have multiple imaging. We'll talk about it in the next few slides. Regarding the management, in the management of any critical patient, you will intervene before you go to any other step. While when the patient is not critical, you will delay the management until you have a good and provisional diagnosis. And what we mean about disposition is this patient is dischargeable, is this patient should be seen by other services for admission or a near follow-up, or if the patient need ICU admission. This approach usually it will not take about 10 minutes in our ER. Okay, the management at this position it could be delayed, but usually within 10 minutes you will see patient, you will have your history, you will have your physical examination. Also, you will keep in mind what is your intervention that you will do, and eventually you have initial plan about the disposition of this patient. For example, if the patient came with right iliac fossa pain that is migrating from the periumbilical area, and the patient has a low-grade fever and repeated vomiting, and when you do your examination, he has right iliac fossa tenderness with a rebound tenderness. So most likely you will say this patient has an appendicitis. You will give him pain analgesia. You will order for him a proper imaging. But in your mind, you know that this patient, eventually he will end up with the GS consultation for the definitive treatment. So this schedule is very important for most of us in the OSCE exam, as well as during your ER rotation when you are seeing a critical patient or even stable patient. So this is some hints that when you have a patient with abdominal pain that he has tachycardia and hypotension, you will think about sepsis or that the patient has hypovolemia. If the patient is tachypneic, it could be due to his pain, or it could be something else that is related to the metabolic acidosis, like in patients with DKA, for example. Usually fever suggests infection process. As we said, almost always it's important to look if the patient is sick or not, regardless of the patient vital sign. Even if his vital sign is okay, but the patient looks sick, sometimes the vital sign will not show deterioration as the patient look. Does this patient need urgent intervention or not? So for example, if the patient came with GI bleeding, even if his blood pressure is okay, but and his hemoglobin from the BBG is okay, but you think that this patient has a massive GI bleeding, you will order blood without waiting any labs or anything. Almost these things will be done simultaneously, so it's not something that is step by step. In the ER, everything will be done at the moment. You will see the patient, you will take the history. While you are doing the examination, you will ask the nurses to do some lab and intervention in the same moment. That's why almost every patient will not take more than 20 minutes. About the bedside imaging, we have the luxury of bedside ultrasound, and we have the portable X-rays as well. Okay, about the early consultation. In some situations, it is important, even if you do not know the diagnosis or the proper diagnosis, but you are thinking that this patient need a surgical intervention, it is important to contact the proper service early, so they will be prepared and the patient will get the proper intervention in the proper time. As we said about the history, it's almost always, as we know in medical school dysmnemonic, it's almost always to ask about the progression and migration, because as we said that the patient will start most of the GI symptoms, it will start by visceral pain and then it will go to be somatic. Keep in mind that colic pain, it's almost caused by a hollow organ. So we know that biliary colic because this the duct is a hollow organ. The small intestine, the ureteric stone as well. Any pain out of proportion, and when we said that pain out of proportion, that means you give the patient analgesia and then you reassess him, still the patient in severe pain. You give him another dose of a proper analgesia, still he is in pain. This will make you concerned about ischemia. Keep in mind to rule out the other critical diagnosis, which we always which are the important negatives. It's important to ask about the females about their menstrual bleeding or the last menstrual period. Why? Because sometimes it could be related to their either the pain it's related to their menstruation or if there is any possibility of pregnancy. As we said that the presentation of ectopic pregnancy is quite similar to appendicitis, especially if it's happening on the right side. So the patient will come with right iliac fossa pain. The patient will have a severe pain. Sometimes they don't have any vaginal bleeding. And when you do the examination, you will find that the patient has right iliac tenderness, and she had sometimes rebound tenderness, and you will think about appendicitis. But the more critical diagnosis at that time is the ectopic pregnancy. So it's important almost always to ask about the last menstrual period and to do urinary pregnancy test, even if the patient deny this history. Don't forget the past medical and surgical history and the medication. Sometimes all the abdominal pain end up to be caused by medication like metronidazole or iron, for example. Okay, it's important when you do physical examination, always expose the abdomen. Even if you are a male and you examining a female patient, the abdomen. Sometimes you will find that the patient has dermatological issues. Sometimes patient have, for example, sometimes they will have a fistula with the discharge. You will find infected surgical incision. If you do not expose the abdomen, you will easily miss this finding. Also, you have to expose the back and to see if the patient has any infected bed sore, and it could be the source of the infection for some of the patient. Look for skin rash. Regarding the rectal examination, it's not mandatory to do a rectal examination for all the patients who are coming with abdominal pain. Maybe the most important time to do the rectal examination when you are suspecting that the patient has localized pathology like hemorrhoid or fistula, or you are thinking about GI bleeding, so we'll do PR to look for melena. Pelvic examination for the female patient when it indicated, usually when they have a lower abdominal pain, it's very important to do pelvic examination. And do not forget the genitalia. Sometimes, especially those patients who are diabetic, when they have a foreign gangrene, which is the necrotizing fasciitis of the scrotum, they will present to you with lower abdominal pain, and sometimes they will have some sort of scrotal discomfort, but because of their neuropathy, they will not sense the pain as if it came to a normal patient. So if you not expose the genitalia, you could miss a deadly diagnosis for this patient. Almost always do a repetitive examination and observation. If you see a patient and you have a finding on his examination, give him the analgesia, and then after half an hour or 20 minutes, go and repeat the examination. Sometimes repeating the examination will give you a proper estimation of what is going on to this patient. Okay, now what are the critical diagnoses that we should think about when we have patients with abdominal pain? Not all of these critical diagnoses is related to the GI. So, for example, rupture ectopic pregnancy, they will usually have lower quadrant pain on the right or the left side associated with the prolonged or missed menstruation. Their abdominal examination will show some sort of tenderness, and it's important to rule out this diagnosis. Even if you are thinking that the patient has appendicitis, for example, still you have to rule out this diagnosis. All these list the critical diagnosis and emergent diagnosis. This is the most important diagnosis to be ruled out in any patient with abdominal pain. So if you have a patient with abdominal pain and you rule out all these diagnoses either by history, by physical examination or investigation, you will not be worried about the patient, and you can discharge the patient safely if he is asymptomatic. But at least you will know that the patient, he will not eventually die from missing one of these diagnoses. Uh, we have here in the list the critical diagnoses, which are the life-threatening condition. If you didn't do a critical intervention in a timely manner situation, you will end up with uh, mortality for this patient. And the emergent diagnosis, it is important to diagnose these patients and not miss them, because if they are missed, they will have a bad prognosis associated with some sort of morbidity. So we have rupture or leaking abdominal aortic aneurysm. We have mesenteric ischemia, intestinal obstruction, perforated viscous, massive GI bleeding, acute pancreatitis, and inferior MI. It's important to know what is the presentation of each one of these diagnoses. So when you go to the patient, you will ask him about these symptoms just to rule out all these critical diagnoses. And as you read about the differential diagnosis, as you read about these diagnoses and to know what is the physiology or the pathophysiology of these diseases, you will be more familiar how to rule out these critical diagnoses. Okay, this is the most useful laboratory investigation in case of abdominal pain. CBC, it's important because of the WBC count and the hemoglobin level. The most cost-effective test is the urine analysis and pregnancy test. Electrolytes, looking for the complication of the repeated vomiting or the electrolyte imbalance. As we know that hypercalcemia could present with abdominal pain as well. Blood glucose and PBG, because we are thinking about metabolic causes. Liver enzyme coagulation profile, lipase for pancreatitis, and lactate will increase in any case of stress. And regarding the abdominal pain, it's very important to assess the ischemia, the mesenteric ischemia, or the hydration status of the patient. About the imaging modality, we have plain abdominal X-ray. Actually, it is not routinely done, and it doesn't have a good clinical values. So mainly the two indication to do plain abdominal X-ray is if the patient has a foreign body and you are not intended to do CT, or if you're thinking that this patient has a bowel obstruction and you want to see the air fluid level. Regarding the perforated viscous, it's better to be detected in upper right chest X-ray rather than the abdominal pain. So whenever you have a suspicion about perforated viscous, you have to do upright chest X-ray. The modality of choice is the CT scan because it has a high sensitivity and specificity for almost all of the abdominal diseases or the GI related disease. The ultrasound is superior for the biliary diseases, and if the patient is a female and you are thinking about the pathology of the reproductive system, you have to keep in mind the CT. It's easily to be ordered, but it has a high risk because with each patient, there is a risk of fatal malignancy in one patient when you are doing CT in 2,000 patients. So if we have 2,000 patients, all of them, they did CT, one of them he will develop or he will increase the risk of fatal malignancies. So it's not an easy decision to do CT for everything. You have to be specific when you're asking the CT. Okay, let's talk about the diagnostic approach for abdominal pain. So the first thing is to see if the patient has a signs of shock. Is the patient is hypotensive? Is the patient has a decreased mental status that uh, give us a hint that the patient has a low perfusion? This patient has a cold extremity. If it is a yes, so you have to intervene. You have to have IV access to start IV fluid. If you are thinking that this patient need blood, consider the blood from now. Do not wait. It's very important always to be uh, initiative and to start the intervention early. So after that, after you're giving the fluid and you have your access, take a quick history. If the history is suggesting acute abdomen, you have to consider either imaging or calling the proper service early. If the patient has a suspicion of pregnancy, so you have to send the patient to do immediate ultrasound to rule out ectopic pregnancy, because it is the most critical diagnosis in pregnant patient. Before that, if you do the abdominal examination, if you have peritoneal sign, that means you have tenderness and you have rebound tenderness, you have to consider to do upper chest X-ray to rule out perforated viscous and to do CT if it is indicated. After that, what is the maximal area of tenderness? So in the upper abdomen, the most important diagnosis in the GI symptoms, if the patient has biliary issue, if the patient has hepatic disease, or if the patient has a pancreatic issue. This is regarding the GI symptoms. We know that you have to do cardiac enzyme to rule out the cardiac issue, not for all the patients, but for specific population, those who are elderly and has a high risk. You will do ultrasound if you are suspecting biliary disease. If the patient improved with pain analgesia and his lab is okay, you are not obligated to do CT for this patient. So a CT for abdominal pain is not it's not always indicated. If the patient has a lower abdominal pain, so do the pelvic examination, urinalysis, and then waited. Do I have to go to do CT or ultrasound? Usually in the female patient, we'll start with ultrasound because of their reproductive system, while in most of the cases in the male population, you will start with the CT imaging. If the patient is diffused, you have to consider the critical diagnosis. The patient could have perforated viscous. This patient could have mesenteric ischemia. Give the patient proper analgesia. Give him symptomatic treatment. If still the patient is symptomatic and not improved, you have to do CT for this patient, even if his lab is okay, but the examination is not reassuring, you have to do CT. So regarding the limit, it's almost always, this is about the previous slides, and this slide, this is applicable for all the complaint of abdominal pain. So in the abdominal pain, the management will be IV fluid if the patient has shock or blood. If the patient have a pain, we'll give him pain analgesia. For example, opioid is the most effective analgesia. But for example, if the patient came with biliary colic, could give him morphine and ketorolac as well. If the patient has a renal colic, it's important to give him also opioid and NSAID, which is ketorolac. So every pain, it should be resolved. You have to give him pain analgesia, not always opioid. You will assess the severity of the pain and you will act accordingly. If the patient has vomiting, you will give him anti-emetic drug like ondansetron, ondansetron. If the patient has a suspicion of infection, like if you think that this patient has a fever or this patient has a peritonitis, so it's important to start the patient empirically in antibiotic. So most of GI infection it caused by a polymicrobial uh, organism. So you have to cover the gram-positive, gram-negative, and anaerobes. So what are the regimens that used for GI infection? You can give second or third generation cephalosporin plus metronidazole. You can give fluoroquinolone plus metronidazole. If you want to give only one agent as an IV, you can give tazocine. If the patient is known to have a recent use of antibiotic of has a resistant, you can give carbapenem like meropenem. If the patient is still dehydrated, we'll give him fluid. And this is what we call it whenever you have supportive treatment, this is the supportive treatment. By the end, as we know that about 50% of the patient, you will not diagnose them in the ER. So if you diagnose the patient, you will manage the patient according to his diagnosis. If the patient has acute appendicitis, you will give him a proper antibiotic and you will refer him to the GS. If the patient has acute cholecystitis, you will give him analgesia, you will give him antibiotic, and you will refer him to GS. If the patient diagnosis is unknown till now, you will look, is the patient symptoms resolved or not? If the patient is resolved and the physical examination is reassuring, that means he has no focal tenderness or rebound tenderness and there is no peritoneal sign, his vital sign is okay, you can either discharge the patient with near follow-up or admit the patient for observation. So to admit the patient, if the patient, you are thinking that this patient has a serious underlying disease, but he is coming early on, or if the disease progression is, there is a high likelihood of this disease to progress, or the adverse outcome is very high, or there is a difficulty with arranging follow-up, like these days now, as we know that during late holidays, there is no OPD follow-up. So like these circumstances, you have to keep it in mind. I will not discharge patient with not reassuring examination without a proper follow-up. So sometimes we will consider admitting the patient just to observe him for 24 hours. And then if the patient not deteriorating, you could discharge him. It's also important to know if the patient is reliable and able to back to your ER if the disease progress. So when you will discharge the patient and you label him as a non-specific abdominal pain, if the patient from the start, he is clinically stable. If the abdominal examination is reassuring, if his symptoms is totally resolved or controllable, that means you give him analgesia, it's totally went out. If the patient could take fluid by mouth, we are concerning about fluid rather than the solid food. Sometimes some of the patient, they have some sort of anorexia and decrease oral intake, but when you ask him about taking fluid, he easily can take fluid, and this is the most important thing. We can take our glucose and our supplement from fluid, not only the food. But when you discharge these patients, you have to educate them how they will relieve their symptoms and when to seek urgent care and to return to ED, and with which specialty he will be follow up. He will do his follow up and why. So this is the discharge instruction for this patient. Okay, now we'll go quickly about some of the gastrointestinal emergency. We'll start with the most common surgical, cause of abdominal pain that need surgical intervention. It is also the most common non-obstetrical abdominal pain in pregnancy. It's common to have appendicitis in patients who are pregnant. So, and they are usually have atypical presentations. So keep in mind, those patients who are pregnant, they are not immune to have appendicitis. So talking about a little bit about the anatomy, it's a blinded end tube that originates from the cecum 3 centimeters from the ileocecal valve. Usually it's length from 8 to 10, and that's why sometimes they have right iliac fossa tenderness, and sometimes they have atypical location of the pain. The normal diameter is from 6 to 11, and the wall thickness about 1.5 millimeter. The sensory fiber is from T10, and usually that's why the beginning of the pain it usually occur at the level of the umbilicus. The appendix become inflamed when there is an obstruction that lead to luminal distension that will irritate the visceral peritoneum. This irritation and this stimulation will irritate T10, and you will have periumbilical pain. With time, the capillary flow will be compromised because of the distension, and the bacteria will invade this wall. And at the end, if the patient is not picked at this level, the appendix will eventually perforated, and the patient will have peritonitis. So the classic triad of appendicitis is that the patient is young, has periumbilical pain that is migrated to right lower quadrant, and he has right lower quadrant tenderness. But unfortunately, it's only appear on less than 50% of the patient. What are the important history question or history finding that increase likelihood of appendicitis? The first thing is right iliac fossa pain. The migration of the pain, the pain is preceding the vomiting, not the vice versa. And there is no previous similar attack, because when the appendix is inflamed, it's inflamed. It's not like the biliary colic that the patient has a recurrent episodes. And as we know that from the pathophysiology of appendicitis, whenever the pain, whenever the time goes, the pain will get more worse and worse. Regarding the physical examination, the most important sign and the most highly specific is to have right iliac fossa tenderness at the McBurney point, abdominal, then followed by abdominal wall rigidity. Okay, rebound tenderness, percussion tenderness, and psoas sign. This is the specificity and sensitivity of the sign. So how we do psoas sign, we will let the patient to lie on his left side, the left lateral decubitus. We'll ask him to extend his thigh against resistance. They are usually, if the appendix is inflamed, they will have right iliac fossa pain when they're doing this test. Roughing sign is the pain on the right iliac fossa while you are palpating the left iliac fossa. Operator sign, it's done by letting the patient in supine position and you flex the hip and flexing also the knee. After that, you will do internal and external rotation. With this rotation, the patient usually will have tenderness. So the sensitivity is used to rule out and specificity to rule in. So the psoas sign and Ropsing sign has a high specificity for appendicitis. So their presence mean that the patient has a high probability to have appendicitis, while their absence is not excluding the appendicitis. We have a lot of differential diagnoses. Gastroenteritis could present appendicitis, urolithiasis, IBD. Testicular torsion as well can cause similar presentation of patient with appendicitis. Ectopic pregnancy in female patient, HSP, mesenteric lymphadenitis in pediatric population. Laboratory investigation, usually they are not diagnostic. It's important to know the leukocyte, although normal leukocyte does not rule out appendicitis. C-reactive protein is an inflammatory marker, usually will be elevated in case of appendicitis. Urine analysis is important. Usually they could have a positive leukoesterase, but it's unusual to have a positive nitrate. How they will have a positive leukoesterase? Because sometimes especially when there is the inflammation of the appendix reach and extend to the bladder. So sometimes this irritation will cause some sort of pyuria for this patient. Pregnancy test is an important to rule out ectopic pregnancy rather than ruling in appendicitis. And basic metabolite panel for assessing the severity if the patient is dehydrated or the patient has vomiting. Regarding imaging modality, there is no benefit of doing abdominal X-ray at all in case of appendicitis. Graded compression ultrasound has a high sensitivity and high specificity, and it's usually used for those patients who are pediatric patient or female patient. CT is the test of choice. Almost always it reaches to 100% specificity and sensitivity. MRI usually used for pregnant female, and we'll talk about this later. So what are the findings of ultrasound, CT, and MRI of appendicitis? In the ultrasound, the diameter will be more than 6 to 7, and this is usually the normal diameter. But keep in mind that when you are doing the compression, usually the diameter should be lesser than this. The other thing, non-compressible appendix. There is a secondary sign, which is the fat stranding, or if there is any peritoneal fluid surrounding the appendix, as we can see in this ultrasound. The CT finding, still the diameter, one of the criteria of the diagnosis. The wall thickness, more than 2 millimeter, or if you have classified appendicolith, if there is any periappendical inflammation, almost the same finding in MRI. Usually, if the patient is a male and he is not a pediatric patient, you could refer the patient to GS only according to your physical examination and your history. If you has a high probability that the patient has appendicitis. In pediatric patient, almost always you will go for ultrasound. If the ultrasound doesn't show the appendix, you will involve the pediatric surgery. The pediatric surgery, they will ask for CT if they need to do a CT. Regarding the female, this is the approach. If the patient is non-pregnant, she will go for ultrasound. If the ultrasound is non-conclusive, the patient will go to CT with IV contrast. Sometimes the patient maybe is a low risk and the patient pain is improved. So you can consider, if the ultrasound is negative, to reassess the patient and to see, does this patient really need CT with IV contrast, or I can discharge this patient, and if the symptoms worse or there is any progression, they will come back, and at that time we'll do the CT. Regarding the pregnant patient, you will start with ultrasound. If the ultrasound is negative, you will go directly for MRI. If your facility doesn't have MRI, you will transfer the patient to a nearest hospital with MRI capability. If you don't have any nearby MRI facility, you have to consult the radiologist, the GS and the obstetrician, to consider, shall we take this patient to do CT, or I will take him to OR directly. Why? Because appendicitis in pregnant woman has a high morbidity and mortality. So treatment is supportive, as we said. Antibiotic coverage, usually they give him the antibiotic only will start it when you are confirming the diagnosis. So if you did a CT and end up by showing signs of appendicitis, at that time we'll start antibiotic. Or if the patient is septic and you have to give him antibiotic early. The definitive management is a surgical intervention, and it should be managed by the general surgery. So the disposition is the patient low risk, plus the patient has a negative CT scan. We could discharge this patient even if the patient is symptomatic. If the patient has a positive CT, the patient will end up by admission with a proper surface, which is GS. Sometimes we miss appendicitis. So we have two types of appendicitis that is usually missed, which is tib appendicitis and stub appendicitis. Tib appendicitis is, by its name, it's only the inflammation of the tib. The patient usually they present with typical history of appendicitis. They have clear physical examination of appendicitis. They will have right iliac fossa tenderness, rebound tenderness, but when you do imaging, there is no signs, and this is the cause of false negative CT scan. So this patient usually missed, because usually when you do CT and CT is negative, you are reassured that the patient has no appendicitis, so you will discharge the patient. But keep in mind, some patient may have tib and appendicitis. Stump appendicitis usually missed because this patient usually came with history of appendectomy. But during the surgery, some of the remnant of appendix is not removed. And the inflammation of this remnant will cause similar presentation, and you will not think about at that time about appendicitis because the patient already did appendectomy. But actually this disease is rare. We have Alvarado score. It's a well-known score that is used now for a proper disposition for patients with appendicitis. This is the score, the migration of the pain, anorexia, nausea, vomiting, tenderness, rebound, pain, elevated temperature more than 37, or leukocytosis or shift of leukocyte more than 75%. In 2007, they come with these criteria. So if the patient has Alvarado score less than 3, the patient doesn't have to have CT, it's unlikely to have appendicitis. If from 4 to 6, do imaging. If more than 6, you have to have surgical consultation. And this is what we usually done in our institution. Okay, I will move faster now. Hepatobiliary emergency. Actually, we do not have a lot of hepatic emergency per se, but we have a complication of the liver disease. Like in case of cirrhosis, there is a good proportion of patient, they will present to you with altered mental status that is not caused by anything. So hepatic encephalopathy is an altered cerebral function resulting from a diseased liver. It's pathology is usually unknown, but it's usually related to the increase of ammonia. That will lead to the crossing of this ammonia to the blood-brain barrier and forming glutamine at the CNS. And could cause the toxicity and alter mental status. Their clinical feature, it could be starting from sleep disturbance, cognitive dysfunction, irritability, and could be present with coma. Their examination is not significant, but usually will not see a signs of lateralization. You will not see a weakness on right side or left side or signs of stroke. You might find signs of liver cirrhosis, like ascites and these things. Differential diagnosis, almost always you have to rule out all the causes of altered mental status. If it is neurological, if it is metabolic, if it's related to electrolyte. If the patient has previous episode of hepatic encephalopathy, it's more easier to assume or to label this patient to have hepatic encephalopathy. Usually hepatic encephalopathy is an exclusion, it's a diagnosis of exclusion rather than a diagnosis per se. So if you didn't find any cause of altered mental status and the patient has liver disease, this is usually caused by his liver disease. What are the important labs? LFT, usually it become normal. Ammonia per se doesn't affect the severity and doesn't have any role in patient with hepatic encephalopathy. It's important to do chemistry and electrolyte to look for electrolyte disturbance that could cause his altered mental status. CBC as a routine and CT. CT usually we do not do CT for every patient with hepatic encephalopathy. Usually we did it at the first time, or if we are thinking that this patient could have a neurological issue not related to the liver disease. So management, almost always we will do our ABC. So almost always we have to assess the airway. Is the patient can control his airway? If the patient reach to a level that he has low HCS, you can intubate this patient. If you are thinking that the patient will deteriorate more, you have to hydrate them, treat and repair the cause. Most of the patients with hepatic encephalopathy, they have their inducing cause is constipation. Usually when you give him lactulose enema, they will improve. Correct any electrolyte disturbance. The most important thing that to decrease the ammonia level, either by removing the stool by lactulose orally or by enema, or by giving neomycin or rivaxamine orally, so it will kill the bacteria and the ammonia level will be, or ammonia production will be decreased. There is a complementary therapy that usually prescribed by the GI specialty, and dietary modification. Disposition, it depends on the grade of hepatic encephalopathy. So we have 4 grades. Usually the grade 1 is they usually have sleeping disorder and mild cognition dysfunction. Grade 2 started when the patient became confused and disoriented, while grade 3 when the patient start not to follow the command. Grade 4 when the patient is comatose. Grade 1 and 2, it depends on your clinical judgment, while grade 3 and 4, it's almost always need admission. The second emergency in patient with liver cirrhosis is this patient who has ascites. They can produce spontaneous bacterial peritonitis, and it is a bacterial infection of the acidic fluid, usually caused by the enteric flora. Usually when the patient has a high portal blood pressure, sometimes this high pressure will cause some sort of intestinal wall atrophy, and it will lead to invasion of the bacteria or the migration of the bacteria from the intestinal tract to the acidic fluid, and they will present with spontaneous bacterial peritonitis. Usually these patients, their clinical picture, they will have either fever or chills. They will have ascites, and their abdomen, it will be tender all over, because now the peritoneum is, the parietal peritoneum will be inflamed. They will have rigidity and rebound. So at that time, these patients should have liver function test, CBC, and you have to send for acidic fluid. You will do barosynthesis. It could be diagnostic and therapeutic in the same time. You will send the acidic fluid for cell count, LDH, glucose, protein, culture, gram stain, and pH. If you're suspecting spontaneous bacterial peritonitis, you have to start antibiotic. If there is a high suspicion, that means the patient examination is highly remarkable. But if the pain is not that, the patient has generalized pain, but it's not that severe, you can wait till the result of acidic tap came out. So if the neutrophil more than 250 or the pH less than 7.34 or the pH gradient more than 0.1 or serum acetic albumin gradient more than 1.1, all these findings suggest that this patient has bacterial peritonitis. So at that time, you could start the patient on third generation cephalosporin. If the patient can tolerate oral, you can give him oral ofloxacin, but you usually start with IV antibiotic. If the patient in peritoneal dialysis, you have to remove that catheter and start him intraperitoneal antibiotic. Almost always disposition is admission. Okay, now I will talk about the GI bleed. GI bleed per se is not a hepatobiliary emergency, but usually those patients who has cirrhosis and portal hypertension, eventually they will have esophageal paresis. So our talk now not only about esophageal paresis, now we'll talk about GI bleed in general. So it's either upper GI bleeding or lower GI, and it's determined by the ligament of Treitz. Upper GI bleeding has higher mortality than the lower GI. The peptic ulcer disease, almost more than 50% of upper GI bleeding is caused by peptic ulcer disease, while most of the causes of lower GI bleeding is caused by anorectal causes like hemorrhoid, fissure, or fistula. Most causes of death that is related by GI bleeding is either from esophageal paresis with a mortality rate of 30% or aortoenteric fistula. Aortoenteric fistula is a fistula that communicating the abdominal aorta with the small intestine, usually in the duodenum. Keep in mind, not all patients with melena or patient with red color vomitus equal upper or lower GI bleeding. Bismuth medication can and activated charcoal and iron can present with black stool. Nasophageal bleeding could be missed or could make you confused. Is this related to the epistaxis or this is an upper GI? Uh, for female patient, vaginal bleeding and hematuria, it could be missed like it's from the GI tract rather than from the reproductive system. There is high risk population for GI bleeding. Those patients who has peptic ulcer disease or those patients who have or who are on aspirin NSAID, steroid or anticoagulation, patient who has liver disease or those elderly patient, alcoholic patient, and those patients who are smoking or heavy smoker, or those patients with multiple comorbidities. So this risk factor should be including in your history when you are dealing with patients with GI bleed. So what is the important historical information that could be gathered and it could change your management? It's important to know if the patient has a period GI bleeding. So if you have a history of previous GI bleeding, they will usually will know the cause. So if the patient have previous GI bleeding and they did endoscopy and he has esophageal varices, this bleeding, it's most likely to be the same. It's caused by esophageal varices. If the patient did endoscopy and he has peptic ulcer disease, still the most cause of his bleeding usually caused by the peptic ulcer. It's important to know the severity, frequency, and quantity of the bleeding because this will direct your aggressiveness of your management. Appearance and color of the bleed. Sometimes the labs will not change, but the patient become more pale and the patient appearance doesn't look well. You have to ask about the risk factor that I mentioned previously. Prior history of GI bleed, this is repeated, and symptoms associated with GI bleed. Sometimes they will present with symptomatic anemia. Sometimes, especially those patients who are cardiac and has coronary diseases, they might have a concurrent chest pain that caused by a decreased hemoglobin capacity, and what we call it as a demand ischemia. And this patient could have MI, but their treatment actually not the cath, rather than restoring the blood volume. Important examination finding. It's important to assess the mental status because it is the best indicator of the blood or the brain perfusion. General appearance, form or cord. Ecchymosis could give you a hint that the patient might have coagulopathy. If the patient has signs of cirrhosis, most likely the cause is esophageal varices. We'll look for abdominal tenderness. Rectal examination is very important for this patient. Endoscopy, when you are suspecting that the patient has a lower GI bleeding and it could be a local. So what are the investigation used in GI bleed? You have occult blood and guaiac bedside testing, and this occur after you do PR. You will take some of the stone and put it on the paper. The paper will turn to blue if there is a blood because the hemoglobin will be oxidized and the color of the paper will be changed. CBC is important because you have to see the hemoglobin drop or make it as a baseline. Coagulation profile is important. Sometimes the cause of GI bleeding is related to medication or the anticoagulation. Renal function, it's useful if the blood urea nitrogen PO in creatinine ratio more than 36 in absence of renal failure. It's a highly specific to be caused by upper GI bleeding. Lactate level is important for assessing the resuscitation process. Type and screen, cross-match and non-cross-match is a very important lab investigation. Type and screening. This is only when the patient has minimal bleeding and you want only to time and screen his blood. Cross-match, when you have a time, but non-cross match if the patient is unstable and you want to give the blood now immediately. ECG, it's important for this patient because we are afraid of the cardiac complication that caused by losing blood. Imaging, you will do abdominal X-ray if you are thinking about bowel perforation, but CT, in case of bowel perforation, it's more accurate to ask for CT rather than abdominal X-ray only. Endoscopy is the imaging of a choice. It is diagnostic and therapeutic as well. CTA and conventional angiography is not really used nowadays. Endoscopy is the most useful imaging, but it usually it's delayed because it's done by the gastroenterologist. So if you have a patient with GI bleed, you have to ask yourself, is this patient is stable or unstable? If the patient unstable, you have to resuscitate the patient. And resuscitation including that if the patient needs intubation, if the patient has massive GI bleeding, you are afraid that the patient could aspirate his blood and he will went for another complication. So you could secure his airway by intubation. And when you will intubate him, you will intubate him by rapid sequence intubation. Keep in mind to restore the blood pressure. It's almost, if the patient losing blood, please resuscitate him by blood, because if you give IV fluid could be temporary till the blood came. But if you lose blood, please replace it with a blood, not fluid. NG tube, usually in the ER, it's not very useful as a diagnostic process. Usually, the gastroenterologist benefit from NGT more than us. So do not insert NGT except if the gastroenterology want to take the patient to endoscopy. So NGT aspiration will cause a better visualization during endoscopy. Regarding ceftriaxone is indicated in case of variceal bleeding. So you will give ceftriaxone only if you are thinking this patient has a variceal bleeding, because it is the only medication that affects mortality. It will improve the mortality, especially for variceal patient. If the bleeding not variceal in origin, don't give ceftriaxone. Octreotide almost given to all patients with upper GI bleeding, although there is no evidence suggesting the mortality benefit, but theoretically, octreotide decreasing the blood flow to the splanchnic organ. So theoretically, it will decrease the bleeding and it will decrease the need for blood transfusion. PPI, as an emergency physician, you don't have to give the patient PPI. Usually PPI given when the patient want to go to endoscopy, but it is not a therapeutic medication for the GI bleed. Single stick and tube is a tube with the two balloon, gastric balloon and esophageal balloon. Usually it is inserted when you are thinking that the patient has a variceal bleeding. So as we can see, you will start inserting as an NGT or OGT. You will advance it you will advance the NGT by measuring the depth that we'll use, like you are measuring the OGT. After that, you will push 50 cc of uh, uh, of normal saline of air, and you will take X-ray to make sure that the gastric balloon is inside the stomach, not in the esophagus. When you are making sure that the balloon is in the stomach, you will give another 450. So in total, you will give 250 cc. After that, you will pull the gastric balloon until you have a resistance. So at this time, you will compress the area between the stomach and esophagus. After that, you can inflate the esophageal balloon. And esophageal balloon, you will depend on the pressure rather than the amount of air. So you'll put the manometer and you will inflate until you reach to a level of 40. Regarding reverse coagulopathy, if the patient on warfarin or any anticoagulation, you have to reverse it. In case of warfarin, you will give PCC, you will give fresh frozen plasma, you will give vitamin K. If the patient has massive GI bleeding, involve the gastroenterologist early, so he will do the endoscopy early, and he could stop the bleed, because the endoscopy is diagnostic and therapeutic as well. He could stop the bleeding by the endoscope. Massive transfusion protocol. There is an experience opinion about when to activate the massive transfusion protocol. If the shock index more than 1, and shock index is when the heart rate divided by the systolic blood pressure. So if the patient heart rate is 140 and the blood pressure is 100, so the shock index will be 1.4. So it's more than 1. This is one of the indications to activate the massive transfusion protocol. If the patient has ongoing brisk bleeding, and you have ongoing blood transfusion without improvement. If the patient received 4 units of blood within 1 hour, or he didn't stabilize by 4 units, this patient should activate the massive transfusion protocol, and usually they give with a ratio 1:1:1, which is the fresh frozen plasma platelet and red blood cell. You will resuscitate the patient until he come stable. At that time, we'll take history, physical examination, and you will do test. If the history is suggesting upper GI, how the history will suggest that the patient has upper GI bleeding? If the patient has hematemesis or coffee ground hematemesis, this is usually caused by the upper GI bleed. If the patient has melena, this is usually caused by upper GI bleeding rather than lower GI. If the patient have a massive GI, as we said earlier, consult the GI service. If the patient is stable and the patient has no massive upper GI bleeding, now we'll divide the patient to low risk and high risk. Low risk, they will be discharged with near follow-up. The high risk patient will be admitted, and we will know which of which. If the patient has lower GI bleeding, usually by suggesting by fresh blood per rectum, but also sometimes brisk upper GI bleeding could present with fresh bleeding per rectum. So you have to do local examination, and you have to do endoscopy to localize the source of bleeding. If you cannot see it, if you see the bleeding source and the patient is vitally stable, and now there is no comorbidity and no coagulopathy, and the patient is young, you can discharge the patient. If it's not, the patient should be admitted for investigation, or if the patient is stable and he is dischargeable patient, you could do an ear follow-up with proper service. This is the two scores that is used in case of GI bleeding, the Glasgow-Blatchford score, and this score used to guide the intervention. So 0 mean low risk, 1 and above mean high risk, and this depends on blood urea nitrogen, hemoglobin, systolic blood pressure, pulse, melena. So anything in this score, if he has only one criteria, he will be high risk for intervention. And we mean by intervention that he might need endoscopy, he might need intervention, and may the patient has a risk of death. The other score, which is the rock call risk score, this score is give a risk is a score used for risk of mortality. It's depending on the age, shock, and comorbidity. As we can see in the right area on the screen, if the patient has 0 score, the chance of mortality 0.2, and this is quite a low mortality risk. So you could discharge the patient. But if the patient has only 1, the chance of mortality is 2.4. So all the patient with 1 and above should be admitted. Okay, now we'll move to the more easier emergency, biliary colic. Biliary colic is usually caused by stone that present on the gallbladder, and when it passes the biliary duct, it will cause hyperactive peristalsis that causing biliary pain. The risk factor: age, female, obesity, rapid weight reduction, cystic fibrosis, oral contraceptive, and familial tendency. The clinical feature, they have right upper quadrant pain. It could be colicky and it could be steady. So it's not almost always important to have a colicky pain in the right upper quadrant. So and you will say this is a biliary colic. Sometimes the pain, it could be steady. Usually they have some sort of radiation to the shoulder. The characteristic of the biliary colic that the patient have multiple episodes of biliary colic and usually related to food. The investigation usually here is to rule out other critical diagnoses. You will do LFT to rule out any hepatic issue, or to rule out acute pancreatitis. In case of increase of alkaline phosphatase and bilirubin, this will suggest that there is some element of acute pancreatitis, not only the passage of the gallbladder stone. Lipase is important because the most common cause of pancreatitis is gallstone pancreatitis. CBC, looking for leukocytosis, although it's not specific or sensitive. Electrolyte, because of the abnormality that could be caused by the decreased oral intake or repeated vomiting. Chest X-ray, sometimes patient with lower lobe pneumonia on the right side could have similar presentation, and sometimes, believe me, they have a positive Murphy, and it's caused by the pneumonia, not caused only by inflamed gallbladder. And and when you do the X-ray, you will find that the patient has pneumonia. Ultrasound is the diagnostic modality of choice in the biliary disease. And what you will see stones with acoustic shadow. Management is supportive. Usually you will give him painkiller, you will give him fluid and electrolyte correction. Definitive treatment, if the patient has recurrent biliary colic, they might do cholecystectomy. But if the patient had one episode, you can only control the patient pain and discharge the patient with follow-up with GS, general surgery. Sometimes you have to admit patient with biliary. But what are the indication? It's uncontrollable. If the pain is uncontrollable, you give analgesia, but still there is no improvement. If there is intolerance to oral intake because of the severity of the pain, if there is CV, a significant electrolyte disturbance, which means that the patient has repeated vomiting and severe pain that lead him to have some sort of electrolyte disturbance. If the lab find a finding suggesting obstruction, that means he has high alkaline phosphatase, he has high bilirubin, it might affect the liver, so he will have high liver enzymes. Or if you are suspecting cholecystitis. So the second emergency in the biliary tract is the cholecystitis, which is the inflammation of the gallbladder. It will usually caused by an obstructing stone in the cystic duct that lead to inflammation of the gallbladder wall. So the risk factor is the 4F, female, 40, which is age, fertile, and fat for obesity. They are usually came with right upper quadrant pain. Usually they have an previous episode of biliary colic, nausea and vomiting. Sometimes may have a fever or may have not. There is a radiation of the pain, but the most important thing is that they have right tenderness of the right upper quadrant and they has a positive Murphy sign. CBC will show leukocytosis. LFT, they might have elevated liver enzyme or alkaline phosphatase and bilirubin. Labs should be requested because we don't want to miss gallbladder pancreatitis. So imaging, ultrasound is the imaging of choice. As you can see in the image, the finding is patient has multiple stones with acoustic shadow. This is the first one. The second one, that the patient has very cystic fluid, and they have thickening of the anterior wall of the gallbladder more than 3 millimeters. The fourth sign is ultrasonographic Murphy sign. This is the fourth finding of ultrasound in case of acute cholecystitis. The most accurate examination is hide scan. The patient will be injected by ionized material that will be absorbed by the hepatocyte and it will be secreted through the biliary tract. If there is failure to detect the gallbladder, this usually will be diagnostic for acute cholecystitis. CT scan is really to be used or used as a diagnostic modality for patients with cholecystitis. Management is supportive. We'll start antibiotic, as we said. We'll give second or third generation cephalosporin with metronidazole. If you want to give only one agent coverage, you will give tazocine. Definitive management, patient need cholecystectomy, but it will be under the general surgery physician. This physician is almost always admission. The third biliary risk factor is the third biliary emergency is cholangitis, and this is one of the deadly and high mortality disease. It's caused by bacterial infection. It's precipitated by obstructing stone in the common bile duct, usually caused by bacteria from the intestine. The clinical feature is Charcot triad, which is right upper quadrant pain, fever, and jaundice. There is renal pentad when the patient has hypertension and other mental status. You will have leukocytosis and markedly elevated liver enzyme. This diagnosis is usually a clinical diagnosis. If you say patient with a fever, with fever, jaundice, and right upper quadrant pain, this is ascending cholangitis. If there is uncertainty of diagnosis, you can do ultrasound. It will not show a common duct stone, but you will see that the duct is dilated. Also, the intrahepatic duct will be dilated as well. You can use CT as well. ERCP is diagnostic and therapeutic as well by removing the obstruction. Hydration is the management will give a good hydration, will give vasopressor. You will give antibiotic. Tazocine is one of the big gun that used for them. Definitive management is biliary decompression, either by ERCP, by surgery. It should be resolved. These patients usually they will be admitted. Okay, so the last topic, which is acute pancreatitis. So acute pancreatitis is inflammation of the pancreatic tissue that caused by inappropriate activation of digestive enzymes. Mortality rate from 4 to 10% up to 30% in severe cases. And this is one of the critical diagnoses that should be ruled out when you are thinking about pancreatitis. The most common causes gallstone from 40% to 70%, followed by alcohol consumption and ERCP. The clinical feature, they usually have constant epigastric pain that is radiating to the mid back or flank. They will have repeated nausea and vomiting. They usually have some sort of tachycardia. Fever is not mandatory. Sometimes they will have a low grade fever. Colon sign and great internal sign, it is usually came when there is hemorrhagic pancreatitis. They have usually in the examination epigastric tenderness. So to diagnose pancreatitis, you have to have 2 criteria out of 3. So typical history, which is epigastric pain that is radiated to the back associated with nausea and vomiting and epigastric tenderness. Laboratory result, the most useful marker is lipase that is elevated more than 3 times of the upper limit. Amylase is not anymore used because it's not specific for pancreatitis. LFT, usually it will be normal, but it could give you a hint that the patient has gallstone pancreatitis. Electrolyte, because of the repeated vomiting, you don't want to have electrolyte disturbance. Also, in some cases of pancreatitis, they will have hypocalcemia and hypomagnesemia. So you have to order extended electrolyte. Imaging, usually in the diagnosis, you don't have to do imaging at all. But when the diagnosis is not 100 sure, you are not sure that the patient has a pancreatitis, you can do imaging. Okay, but the best time to do CT with contrast is to assess the complication of the pancreatitis, which occur 3 to 7 days after the diagnosis. MRI could be used as well. Ultrasound is usually used to look for biliary stones, so you might give you a hint that the most likely cause is biliary pancreatitis. So to assess the severity, we have ransom criteria at admission and at 48 hours. As we can see, the WBC, glucose, age, AST, and LDH at admission, and at 48 hours, we have the hematocrit drop, blood urine nitrogen, calcium, partial pressure of oxygen, base deficit, and fluid sequestration. If each one of them, if there is two or from 0 to 2, they have a risk of 1% of mortality. If there is more than 7 of these criteria, the mortality approach 100. So this criteria used as a risk of mortality, and accordingly you could discharge or admit the patient. So these patients with acute pancreatitis, they have to have volume replacement for their fluid loss, electrolyte correction, especially calcium and magnesium, correction of hyperglycemia because of some cases of pancreatitis. The endocrine function of the pancreatitis pancreas could be affected. They have a severe pain, so make sure to control their pains and to give them antiemetic. It's important to start oral nutrition rather than keeping the patient MPO, because there is no difference between starting the patient on TBN, which is total parenteral nutrition, and starting the patient oral feeding. They found that when you start the patient on TBN, they usually have a longer course of pancreatitis, and the abdominal or the stomach and intestinal villi, it become atrophied. So that's why they encourage to start oral intake. Antibiotic is not important in case of pancreatitis, except if you are suspecting infected necrotizing pancreatitis. ERCP, if you are thinking that there is an obstructing stone, so it could be therapeutic. Rarely surgical intervention for those patients with acute pancreatitis. So regarding the disposition of the patient, so if the patient has mild symptoms, you could discharge the patient if he has low symptoms and he is not a high-risk patient. But most of the patients, they will get admitted to a regular floor. If the ransom criteria, they have a high score from the beginning, they could be admitted under ICU care. الله يعطيكم العافية جميعا، ومعلش طولت عليكم. حاجة من الأشياء اللي أقول لكم عليها إنه إن شاء الله كلكم عن قريب حتصيروا ريزيدنت، كلكم إن شاء الله حتروحوا التخصصات اللي تبغوها. أهم حاجة الطب ما هو كل حاجة في حياتكم. استمتعوا مع أهلكم، استمتعوا مع أصحابكم، واستمتعوا بالجد والاجتهاد. الله يوفقكم يا رب. أي سؤال، أي استفسار؟
الله يعطيك العافية دكتور عمار، ومن جد كانت معلومات قيمة ومرة استفدنا من المحاضرة. بالنسبة للأسئلة بس في سؤالين. الأول how reliable is a Colorado score to be used in emergency department?
طيب بالنسبة للبراو سكور usually it's used for a low risk patient. okay, يعني هو اليوسفولنس حقه إنه if I want to discharge a patient خلاص I could use the Alfredo score. So if he is 3 and below, you have about sensitivity about 96%, which is a good percentage. يعني it is used for ruling out rather than يعني ruling in.
تمام. بالنسبة للسؤال الثاني, can you repeat the ecturotide rule please in unstable patient?
طيب الاكتوريوتايد ايش الفكرة حقتها؟ الاكتوريوتايد بتعمل فازو كونستريكشن للفيسلز اللي في الجي اي تي تراكت اللي هي سبلانكينج فيسلز. خلاص، ثيوريتيكالي انها بتقلل المفروض البليدنج، فبالتالي بتقلل الحاجه انه اعمل بلاد ترانسفيوجن. although انه باي ستدي ما فيش ديكريز للمورتاليتي. فمفهوم؟
مفهوم. for me it's مفهوم يعني، بس اللي سأل السؤال I don't know. في سؤال ثالث اللي هو patient in severe dehydration because bleeding from BUD. What I should starting.
وات ايش؟
I should starting.
طيب احنا دائما بنقول الاير واي هو اهم حاجه. فاذا البيشنت كان عنده مسف اير واي بليدنج، انا اخاف انه يصير له اسبيريشن. طيب لو صار له اسبيريشن حيصير له هايبوكسيا. طيب كيف البيشنت حيكون عنده لو بلد وحيكون عنده لو اكسجين، فحينضرب عندي البرين وحينضرب عندي الهارت. فالاساس عندي دائما الاير واي. لو البيشنت كان البليدنج حقه ماسف وام ثينكينج انه البليدنج حقه will compromise my airway، اول حاجه حاسويها I will intubate this patient عشان اشيل مشكله الاير واي من راسه. خلاص، بعد كده البريدنج خلاص انت ما دام عملت الانتوبيشن ان شاء الله ما انت خايف على حاجه، حتروح للسي السيركوليشن. طيب انا عندي بليدنج، كيف ممكن اوقف البليدنج هذا؟ البيبتيك ألسر ديزيز ما اقدر بصراحه، ما في حاجه يعني الشيء اللي ممكن يصير انه البيشنت يروح فور ايرجنت اندوسكوبي. بس انا عندي اشياء تمرريه، اقدر اديله بلاد ترانسفيوجن، اقدر اديله اكتوريوتايد which is theoretically ممكن تقلل البليدنج. اول كانوا بيقولوا انه الترانزكسيميك اسيد could be used في السيفير bleeding، بس دحين طلعت new study انه لا. when they compare it with البلاسيبو وجدوا انه بالعكس الترانزكسيميك اسيد بيزيد الريسك اوف في تي اي اللي هي الدي في تي والبي اي والريسك اوف سيجر. خلاص، فما نقدر نستخدمها. الشيء اللي من جد كريتيكال في هذول البيشنت انه انا اسوي لهم ريبليسمنت باي بلد rather than اديهم اي في فلويد، اديهم الاكتوريوتايد. نكلم الجاسترونتولوجي فور ايرجنت اندوسكوبي، لانه الجاسترونتولوجيست هو اللي حيخش بالاندوسكوب حيشوف السورس اوف بليدنج، وعندهم كذا موداليتي فور تريتمنت. يقدروا يدوا له سكليروزنج ايجنت فيوقفوا البليدنج، يقدروا يعملوا الكتريكال كاتري فيوقفوا البليدنج. ف at that time الاي ار جب هناك انه they keep the patient stabilized for the definitive treatment. لكن في الاي ار انهم يعملوا definitive treatment لواحد عنده massive جي اي bleeding صعب.
اوكي. السؤال الرابع why not to withdraw liquids from abdomen in hepatic encephalopathy.
why not to draw fluid.
to withdraw liquids. Yes.
طيب انا ما فهمت السؤال بالضبط، لكن اذا كان قصده انه يعني خليني طيب الهيباتيك انكفالوباثي الفكره وما فيها انه البيشنت كلنا احنا لما نجي ناكل البكتيريا بتسوي فيرمنتيشن للاكل حقنا وبتشتغل فيه. خلاص، فبالتالي احيانا بتنتج الامونيا. مشكله هذول البيشنت انه عندهم كرونيك كونستيبيشن، البيشنت اللي عندهم هيباتيك انكفالوباثي. اللونج شو يسموه ستي حق الفيكال ماتيريال الله يكرمكم في الانتستين بيزود لنا ليفل اوف امونيا. فهي المشكله انا عندي في الستول rather than انه الستومك فلويد او الستومك سكريشن. عشان كذا انا بديله انيما عشان اتخلص من الفيكال ماتيريال، فبالتالي امنع الابزوربشن حق الامونيا. طب ما انا ممكن ما ادي لاكتولوز، ممكن ادي انتي بايوتيك على اساس اني I will kill this bacteria so the ammonia will not be produced. إن شاء الله كده واضح.
واضح يا دكتور، والله يعطيك العافية، وشكرا لتواجدك معنا وعلى المحاضرة الرائعة دي. ونشكر لكم حضوركم جميعا، ونتمنى أنكم تكونوا استفدتوا واستمتعتوا في يومنا قبل الأخير، وننتظركم بكرة في آخر محاضرة في الكورس نفس الوقت الساعة 7:15، وننتظر مشاركة آرائكم على الهاشتاج في تويتر، ويعطيكم العافية جميعا.